medicine cannot evolve to a 9 to 5 job where you just punch the clock and you go home. It is a profession. As a professional, you have a responsibility to moving your profession forward. I hope we will learn from the recent past, fulfill those responsibilities. I think we'll have greater satisfaction.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. This is season 7, and it's the inaugural episode. So happy New Year to everyone. And thanks to all of you who have tuned in every other Monday to listen to Parallax and to listen to all the guests that we've had on the show. My guest on the inaugural episode for season 7 needs no introduction. Dr. Fry is the past president of the American College of Cardiology. I've happened to work with him through the aegis of the Indiana chapter of the American College of Cardiology when I moved to the state now 3 years ago. And it's been great to learn from him. It's been humbling to see how involved he remains despite being at the helm for the college at a national level. He still remains very deeply involved with the state chapter. So that is something I've learned from him. He graciously agreed to be on Parallax to share his thoughts on how cardiology practices have evolved post-pandemic. I think it's been a topic of interest for all of us who work in cardiology across the spectrum of our nation. And pandemic was a significant event in all our lives. So with that introduction and without much further ado, Dr. Fry, thank you so much for doing this for us. Welcome to Parallax. Happy New Year. Happy 2025. And so good to see you.
Great. Thanks, Ankur. And please call me Ed. I know you're being very kind, but it's great to be with you and Happy New Year. And we will all hope for the best for the new year, right?
Yes, we will. We will. I think it's been the excitement. I think is a fair word. Has been palpable amongst all of us for a myriad of reasons. Certainly, with the inauguration that happened just yesterday. It's going to be interesting, and we'll just leave it at that. So I'm going to start this conversation, by asking you, and correct me if I'm wrong, but you were at the helm at the national level when we were in the throes of the COVID-19 pandemic, and I'm sure as much as you heard the evolution in your own practice, which is a very successful practice in the greater Indianapolis metro area, Ascension St. Vincent, you were also hearing from colleagues across the country with regard to how the pandemic was shaping the practice of cardiovascular medicine and cardiology. So I think, for us at Parallax and our listenership and our audience, it would be insightful and enlightening to hear from you, what you learned during those times.
Yeah, well, obviously, it was a transformational time at every level of life, and particularly in medicine and in cardiology. It's interesting. So I was on the board of trustees in 2019, going into 2020, and I had really never considered ascending further in the ACC leadership really until the pandemic hit. And what I came to realize, what I was facing in my own practice and health system and roles that I had in the local and national aspect of the health system were really well aligned with the challenges that we were faced with at ACC at the beginning of the pandemic. And I thought, what I was doing now would sort of prepare me well. And so that's when I made a decision that, well, maybe pursuing further leadership roles within the college was the right thing to do. And in retrospect, obviously, I was very fortunate and benefited from that tremendously. But I think the challenges that were posed to us in terms of, I think it was sort of a series of reactions. First being obviously fear. None of us knew what was going on, both clinically, medically, socially, economic. The whole world was turned upside down, and we had looked pretty abysmal. And I think it created a great challenge in terms of how do you assess, adapt, innovate, and those were, I think, necessary efforts and acquired skills that everybody had to get in a very short period of time. And so when that happened in the spring, so everybody remembers very vividly, March 13th, 2020 is when the country shut down, and so at the ACC, it was a transition between Dick Kovacs who well, also in our chapter in Indiana, was president of ACC at that time, and Athena Pappas was the incoming president, and we actually had to cancel ACC meeting and reorganize and have a whole virtual presentation within a 3-week period of time. That in and of itself was an incredible lesson of adaptability and change and leveraging what were to us then new technologies. And so it was really, Athena really carried the torch that first year through the pandemic. And at ACC, we had huge financial problems. We did benefit from the PPP plan, from the government support, help keep the lights on, keep people employed, keep the educational offerings going. And then Athena passed on the torch to Dipti Chapuria. And then I became president in 22, sort of on the back end of things when we are now approached with some of the consequences of the pandemic, and maybe we can talk a little bit about that as it relates to workforce and everything. So that's kind of a little bit of the history in the background.
I don't think any of us can even fathom preparation, for a natural calamity or an occurrence like this. I mean, I think it's just, as an interventionalist, it's, sort of drawing the parallels between interventional cardiology and how, just being agile and thinking on your feet as case turns differently than what you anticipated. I think some of those reflexes, I'm sure, would have helped you, lead, the college and all of us during those times. I think you ended in a great note for a good segue in that. A lot remained unknown, like you said at the time. Medically, socially, economically, we were just not prepared for an event like this. And you've sort of brushed upon briefly what the challenges were at the time for the college, and how it was supported through federal funding. I think since then, and now in the post-pandemic phase, what are some of the biggest lessons that you've learned, as a leader, as a cardiologist, and as a colleague, to your friends in the community? I think those would be important lessons to, discuss and share your thoughts with our listenership.
Certainly we've had positive lessons and we've had negative lessons. And certainly on the positive side, you alluded to sort of, and I think the clinician community was well suited to respond to this situation relative to the unknowns because of the nature of what we do in terms of having to assess, trying to figure out the unknown, make the best educated decisions with the information that we're given. And when we're faced with situations where it's not, black and white, to innovate and improvise and do, use our problem solving skills to try and come up with the best solution. And importantly, to rapidly assess and then redirect, sort of rapid process improvement, I think was really the name of the game. In terms of some of the positive things, and maybe some missed opportunities too, was that it caused us to pause and look at everything that we did, which we often took for granted and as routine in clinical practice, because we couldn't have the same face-to-face encounters that we had before. Obviously, the rise of telehealth, but beyond that, really looking to, okay, let's see what technology we have around us and how do we apply that. I think about the things about rapid rise of relying on remote patient monitoring, dependence on patients' self-reported results from wearables, using traditional technologies like CT in new ways, like instead of doing, as an example, TE prior to cardioversion, to avoid those risks, relying on CTA to identify left atrial appendage thrombus and using that as a guide. So we had to adapt these things quickly and innovatively. So I think that was one of the great benefits. I think early on we also had, I'd be curious in your own experience, but certainly in my personal experience and looking around through our health system, it drew everybody together. I think everybody came together, the clinician and non-clinician communities were drawn together to solve problems, work very closely. I thought that was very successful. I also think it was one of the missed opportunities because as the initial part of the pandemic waned, and especially as health systems were faced with some of the economic consequences, the mantra was, back to normal as soon as possible. And I think that led to maybe an unintended division between the clinical community and the non-clinical community, with each somewhat in survival mode for themselves and retreating to their areas of comfort. And I think that was a great, if we could go back and do it again, I think we would have been well served to press ahead with taking the opportunity to change the way that we did things permanently. I'll blame the pervasive reimbursement system as a power that I think drove a wedge between those groups, and maybe missed out on ways that we could have delivered care in a very novel and innovative way. Obviously, some other lessons inherent on the job leadership training. I think a lot of people stepped up and took on new roles. I think some personal that could be viewed as both positive and negative. People reassessing their own personal values and goals in life, and obviously some of that led into the Great Resignation things and great rethink phenomenon that we saw that impacted the workforce. But those are probably both put a strain on the system, but they may have been of value to individuals in terms of reassessing, their life priorities, and hopefully that was, had a positive outcome for individuals. So lots of lessons that were there, both medical and non-medical.
Yes, you touched upon workforce, and I think for me, so I was at my former institution in Ohio, and I remember us leading an effort, just to give you, my own experience with um, working together of the clinical and the non-clinical communities within our healthcare system. I think we published this in the European Heart Journal at the time. How art practice transitioned from being an in-person practice to a virtual practice within the spectrum of several weeks, and that level of integration between clinical and non-clinical communities to work together to make sure that we are still accessible to our patients, I think was a highlight for me. Um, and how we did it was something we thought was worthy of writing up and sharing with the community at large. Um, you brought up really interesting points about the workforce. The great rethink and the great resignation. Now that we are 5 years out, maybe 4 years out, d- i- in your experience, and compared with how things were with the workforce pre-pandemic, and now we're on the post-pandemic phase, what are some of the differences that you see in the workforce now in comparison with what it used to be before the pandemic?
Well, I'll address those directly. I just, in follow up to the earlier question about lessons, I would just say again, and this sort of ties into the workforce issue, is I would say from a clinical thing, the overarching lesson was understanding the value of access and chronic disease management. We saw kind of what happens when you don't have those, and that ties directly into obviously the availability of the workforce. You alluded to, I mean, the problems had already started well before the pandemic, whether it was through just aging of the cardiology workforce. I think today the average age of a cardiologist is 57. It's pretty close to the same thing before the pandemic. Hadn't really changed a whole lot. And same was true in nursing. Same issues with respect to aging and sort of career trajectory. So that was present. So that was something that was going to be something we had to tackle. We still had a relatively fixed pipeline of training, and there had not been a lot of movement in terms of expanding GME and being able to increase training slots to to deal with that anticipated supply issue. We also knew that the demand issues would increase over time. The population, the patients aging, 10,000 to 11,000 people turning 65 every day. That would already started well before the pandemic. And we knew that after many years of success in terms of bringing down cardiovascular mortality, we knew that risk factors were beginning to climb again. We were seeing diabetes, hypertension, and obesity in particular starting to rise, and then the influence of disparities in care, which had already been present before the pandemic, but absolutely magnified, especially in the early parts where we saw incredible differences in mortality rates depending on ethnicity, race, socioeconomic status, which sadly have persisted. And then to see all that translate into a dip in our longevity as a country, some of it related to COVID itself, but now as we can look back, particularly the bulk of the rest of that difference has been from cardiovascular disease, and it has been impacted by the workforce situation because access is more difficult. Some of the things that have happened as a result of that, we have seen people as they enter the cardiology workforce now, again, rethinking their priorities. And we see people who want to work less than a full schedule. And that's the price of entry in many circumstances now, which puts additional pressure on the workforce shortage. We see challenges within the training pathway. Surveys have suggested that in medical schools, a significant number of people are rethinking about whether to complete medical school. And we're seeing people, even in cardiology training, only about, about 25% of cardiology fellows actually go on to something that's not clinically related. They may pursue other endeavors, such as working in tech, working in big pharma, working in policy, working in administrative roles. Again, putting pressures on the direct patient-facing workforce. So a lot of moving pieces there, a lot of challenges there. Some of the initial support put out for the pandemic was to be directed towards increasing the number of training spots, not just for cardiology, but residency spots. There were about additional funding for about 1,400 additional residents per year, but that funding got stuck in some of the difficulties with Congress and still have yet to be implemented. So we still have challenges there. They're probably growing challenges, and we have to be equally innovative in terms of trying to address this growing workforce problem.
Yes, and that's an exhaustive list of challenges, and these are all real. The question that I have for you is that, do you think with the resurgence is not the right word. I think with the natural evolution of how the chips fell post-pandemic, do you think all these challenges was the nidus for the private equity phenomenon which we see entering cardiology practices? I mean, do you think that is something which led to private equity entering cardiology practices? Because that was going to be my follow-up question to you. I mean, there have been some, important papers published in, Journal of the American College of Cardiology and even JAMA, looking at private equity and its role within cardiovascular diseases and also patient experience. So I wanted to get your insights, as someone who probably has interfaced this question at the college level.
Yeah, well, certainly we've seen a significant uptick in activity in private equity in cardiology. Although, again, predating the pandemic, private equity was already off to the races and pretty well developed in other areas: dermatology, gastroenterology, orthopedics, things of that nature. And as you alluded to, I mean, there were articles in JACC, and actually I wrote an editorial about this in JACC and kind of what some of the basis of this was, and I do think part of it was, as I'll go back to what I referred to before, is this initial coming together of the clinical and non-clinical communities, and then sort of almost a parting of the ways as we were sort of emerging from the pandemic, and it was a little bit of everybody for themselves, and that coupled with aging groups, and I think those who are in independent practice, feeling the economic pressures, feeling the sort of difficulty as to where to turn. This, especially depending on what their career plans might be, private equity became a attractive opportunity. Now, obviously, that's fairly limited because we know about 85% of all cardiologists are employed, and the obstacles to come out of employment to go into private equity are pretty steep. So this was really reflective of the independence, although there are some small examples of groups of cardiologists who are in an employment agreement, coming out of that employment agreement and entering into private equity. But it's a much steeper climb. Some also fueled by relationship of private equity and ASCs, and an opportunity for physicians, whether employed or independent, to find some additional revenue source and stability that way. Although there've been a lot of challenges because of the labor costs that it takes to run an ASC and the declining reimbursement related to that. So I'm not sure what the future. I think the future is rather challenging for at least cardiology and private equity. I think there may be some aspects of cardiology or cardiovascular disease, like peripheral vascular disease, may have a better home than, say, comprehensive cardiology, but remains to be seen. But I think there certainly were some. I think the outcome of the pandemic certainly did sort of set the stage, at least to get people thinking about were there new ways of structuring their professional life.
Yes, you bring up reimbursements, and in accordance with how you've seen things evolve post-pandemic, how do you think reimbursements have been affected by the phenomenon of the pandemic? And do you see this? I mean, you've sort of alluded to it being a growing challenge. Do you see this become an even more vexing problem, particularly for subspecialists like electrophysiologists and interventionalists, in the post-pandemic phase?
I don't necessarily think that the pandemic was a driver of any of those difficulties. I think the drivers were structural, and they are that we have aging patient population, and we have a funding mechanism that is fairly finite in terms of CMS resources, and so we have demand rapidly outstripping coverage. And we see this. That is the phenomenon of the exercise of the reissuing of the physician fee schedule every year, depending on certain codes and things like that, is that there's a finite bucket of money, and if you give to one silo, you have to take away from the other silo, and so I think that's the primary force. The pandemic may have had an indirect effect in that it may have increased demand for services. Certainly, the recovery from the pandemic, so I think those are the challenges. I tell you what I was really kind of most surprised about our collective, and I'm not just talking about cardiology, but just medicine in general. I would have thought the appetite to move to value-based care would have been much greater, but we didn't see that happen. And we'll come back to, I think it was a matter of, as we were trying to bail, particularly at the sort of health level, the health system executive level, trying to bail ourselves out of the situation, you do what you know best. And I think people reverted to that, and it was a challenging time to take the risk related to value-based care. But I think, again, that may have been a great opportunity, and maybe a great opportunity going forward, and in fact, maybe a great motivator of making that shift.
Yes, just interesting times. I know things are in constant flux and evolution, so I think we'll know with passing time, what private equity does, how reimbursements shape up, what the workforce looks like. The one aspect which I'm sure you would have addressed, even at the college level, is how to circumvent, at least, or curb misinformation or disinformation, which I think was just such an unfortunate byproduct of the pandemic and how information was being shared, being dispensed. Certainly the ubiquity of social media in our lives and, the harms associated with it. I feel that there was a lot of erosion that occurred between physicians and patients. And, I think that relationship is very sacrosanct um, to both us and as well as our patients. And, I think it has been shown to affect outcomes, how patients do after procedures um, or after medical treatments. Um, where do you see, you know, this is gonna be a two-pronged question. One is the role of each one of us individually as we, you know, see go, see our patients in offices and see them in procedure rooms and suites. And then I think on a larger scale as a community, how do you see this? How do we sort of reestablish that trust in science and medicine and in dispensing information, which you and I know is, I mean, it takes so much effort to do a clinical trial and, to get that information in a randomized fashion, which, you can stand up and discern and say, look, this is no other play of chance or placebo effect or a nocebo effect. This is truly making a difference. How do we get that dialogue back into our conversations with patients into our clinics and in our hallways?
Well, there's a lot to unpack there, a lot of concepts. And I think, well, let's go back to like the beginning of the pandemic. Well, what did we do? We told people to stay home. We told them to stay away, and you know, that was a defense. Obviously, we thought it was the right thing to do for their safety, and as well as for the safety of medical staff. Uh, and certainly, I think we, tried to sort of reverse that and rectify it quickly in terms of making access available through telehealth and things like that. And um, but it was, yeah, obviously, in those first couple of months, that was kind of, I think, the public's perception. You alluded to social media. Obviously, that was a just a source, a force multiplier to be able to, anybody with a bullhorn could, suddenly become an expert. And sort of the truth testing was very difficult. I think we also probably had an opportunity that we could have probably done a better job with, because we saw it obviously in some of the national information just about the pandemic itself, is to be more circumscribed about, we don't know what we don't know, and we have to make our best judgments, and to be, to engage patients not only at a national level, but also in a person to person level, to be conversational about it. We need to have a conversation about this, not a dictum. Again, difficult to, hindsight's always 2020 in that sort of circumstance, given the sort of dire nature of the things that we faced medically. And I think, I think the medical community, but I think institutions in general, and we hear about this, took a blow in terms of just trust of institutions, and in some ways we had, we had evolved to a delivery of healthcare really being an institutional process, and by necessity in many cases, but losing the individual relationship. Many of the interactions in medicine became transactional. And I think that was ripe. that created an environment ripe for distrust and created a vacuum for misinformation, disinformation. And my definition of that is something that's malignant and intentional and harmful. Misinformation can be, just incompetence and not intentional. It can have much the same impact. So how do we deal with this? I think we got to get back to basics of trying to earn that trust through communicating and discussing that we don't have the solutions to everything. This is our here is my understanding of the problem. Here is our set of solutions. Jointly, we're going to use shared decision making to come to a best conclusion for you individually. This is going to be an engagement, not a transaction, and there's going to be some connectivity following this. I think those are the steps I think that we can take to try and regain that. Very difficult because you still in the background you still have the chatter of social media and people hear what they want to hear, and obviously we have the political overlay of all of that, and that has not been helpful at all. At a time when we really do need these institutions of trust. So I think we'll go through a little bit of a rocky period, certainly, but I think as clinicians, those are the steps that we can do: engage, be honest, discuss, make best decisions together, own the consequences together, and promote that engagement.
Yes, I think what there's one thing you said here which really resonated with me, which was like own the consequences together. So truly be a partner to your patient, and sort of like and the college has done a phenomenal job, I would say, in promoting shared decision making across the spectrum of all complex decisions within cardiovascular diseases. We see so much of that being rightfully promoted. So, and I think when we are at that space with our patients, which is I consider a very sacred space, then I think they open up more, and that's where they start sharing their vulnerabilities, and we start becoming more honest with what we know and what we don't know. And I think patients really appreciate that. I think they really like when you come forward and say, look, I really do not know, but this is what I know now, and knowing how evidence builds up and we learn more, this can change. So I think just having that partnership upfront early on is crucial, and I think it's gonna start just like the college says, at the Crossroads, which is in our offices, at our clinics. Well, this has been a fascinating discussion. I'm still going to call you Dr. Fry, just out of respect more than anything else, to be honest with you. Is there anything you think is there anything you think I missed that we didn't discuss, or you think we should discuss, or is important to the context of our conversation this evening?
Number one, I thank you very much for the privilege and the honor to be part of this. And these are topics that have every bit as impact on the outcome of a patient as the result of a randomized clinical trial might. So these are I applaud you for integrating this in the overall way that we address patients. I think for me, the number one sort of concept that can remedy some of these things that we talked about from the physician side is engagement. We have to own our future. We have to be at the table. We have to put the work in to become and then deliver on being, at least partners in the with the decision makers related to delivery of care, as advocates for our patients. And so we can't. Medicine cannot evolve to a 9 to 5 job where you just punch the clock and you go home. It is a profession. As a professional, you have a responsibility to moving your profession forward, both in terms of education, research, advocacy, health policy. So I hope we will learn from the recent past and fulfill those responsibilities. I think we'll have greater satisfaction, and we'll feel better about what it is that we're doing individually, but we'll also feel better about what we're doing in terms of delivering highest quality healthcare to our patients.
Yeah, no, very well said. Well, thanks again. This has been very enlightening for me. Personally, I'm sure the audience and the listenership will resonate. And to all of you listening, thanks again for tuning in. Other Monday, do leave your feedback with us. We take it very seriously. If you want to hear back from experts like Dr. Fry, do write to us, and we'll do our best to get them on Parallax. And you can leave your feedback by either emailing us or, sharing the feedback on social media. Again, thanks for tuning in, and until other Monday, we'll see you next time.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.